Good afternoon from the sunny city of Abu Dhabi. I welcome you all to the second day of the 11th International Neonatology Conference. My name is Vincent and I will be your host for today. We had a great start yesterday with over 2,000 attendees watching live. Thank you very much for your continuous patronage, and I'm sure that today's agenda of the conference is going to be fascinating as the first. Our roster of speakers for today are international speakers working in one of our prestigious hospitals in Norway and also the United States of America. I hope our dear viewers for today are here to discuss the latest trend in respirology, ventilation, and cardiology in medicine. But before we start the first session of today's agenda, I would like to make a few announcements. We'd like to acknowledge and give thanks to the organizations that supported this event, and they are the Children's National Hospital, USA, Children's Hospital of Philadelphia, USA, Tracy Pharmaceuticals, Sobi Pharma, Roche, and Prolepta. Ladies and gentlemen, we also urge our attendees to visit the booth of our supporting organizations. If you are interested on their products and services, please feel free to drop a message on the chat box, and the representatives of each of these companies are eager to meet up with you virtually. And later this afternoon, I would like everyone to be present for the symposium on nutrition of preterm babies, lessons learned from cow's milk derived fortifiers with Dr. Boris W. Kramer. We also encourage all our attendees today to participate in the panel discussion by sending your questions to the speakers of each session using the send a message icon on your screens. Today's program is short, but brimming with knowledge and insights and ideas that can help you elevate our practice. We have 3 sessions today, and it will conclude at 19:25. So moving on to our first session of today's agenda, I would like to give a warm welcome to our session chairperson, Dr. Ayman Rahmani. He has a lengthy clinical achievements, including the expansion of the neonatal service at Tawam Hospital, and over the last 20 years of his career, he has published 21 original papers in peer-reviewed journals and over 100 communications and abstract presentations. He also participates in several international conferences as a guest speaker. Currently, he serves as a reviewer, editor, and editor-in-chief for several neonatology peer journals. Dr. Ayman Rahmani, welcome, Dr. Ayman, and enjoy the session as the virtual air is yours.
Good morning, everybody. It's a great pleasure to welcome you to the second day of the 11th International Neonatology Conference. I hope that everybody will get the maximum benefit from all the knowledge that will be shared by all the speakers. We had a great program yesterday, and we have a great number of attendees. We have about over 3,800 colleagues already registered in this conference, and over 2,000 attended yesterday. We have an exciting program today that will complement the really great start that we had yesterday, where we started with a respiratory session, and we had also hematology session, followed by neurology session, and then we ended the day yesterday with quality improvement session. So today it will give me great pleasure to introduce the first speaker of this session, a physician and a teacher and a scientist that he needs no introduction really, Dr. Ola Sagostad. He is well known internationally for his great work on newborn oxygenation. Dr. Ola Sagostad is a professor of pediatrics at the University of Oslo. He's a director of pediatric research and consultant in neonatology and pediatric research department at University of Oslo, Norway. We all know Dr. Ola. He's a member of several European and United States societies of pediatric research and in American Society of Pediatrics. Dr. Ola has been writing extensively his research and publications on oxygen use in the delivery room, which really led to our change in our practice in the delivery room management of newborn and improve the outcome of our unit. Um, Without further ado, I would like to welcome Dr. Ola Songstad. He's going to talk to us about oxygenation in the newborn. Please join me. Welcome, Dr. Ola Songstad.
Thank you so much for inviting me to this 11th International Neonatology Conference in the Emirates. First of all, I'd like to thank my good friends Junaid Khan and Ayman Ramani for inviting me. I have so many good memories from your meetings, and I really wish that we all could have been together. Hopefully, next time that will be possible. So this lecture is about oxygenation of the newborn. And here are my disclosures. And I also put 4 learning objectives for this lecture. First of all, it's to understand the normal development of oxygen saturation the first 5 to 10 minutes of life. And secondly, why the saturation should reach 80 to 85% within 5 minutes in premature infants. And I also would like you to understand the dilemmas of oxygen therapy in the newborn period, especially in the delivery room, and also future challenges and research topics, because there's so many research topics we need to go into the next years to come. So let's start with some historical remarks. Oxygen was described as an element in 1772, and already a few years later it was used in newborn care. For almost or more than 200 years, pure oxygen was used, for instance, during gestation, especially after 1928. However, in the 1990s, 2 studies were published, the RESER 1 and RESER 2, showing that it is possible to resuscitate term and near-term infants with air just as well as with oxygen. And some years later, the first meta-analysis on this topic were published, showing that yes, it is possible to resuscitate with air, and in fact, the outcome is better with air compared with 100% oxygen. So in 2010, ILCOR changed their guidelines from oxygen to air, and I'll come back to that in a minute. At the same year, the first oxygen saturation nomograms were published, showing that oxygen saturation is low immediately after birth and then gradually increases during the first minutes after birth. So the world map regarding newborn resuscitation before 1998 looked something like this. All guidelines recommended the use of 100% oxygen. And those babies who were ventilated at that time, they got this enormous PO2 peak, which we today know may be toxic. So in 2008, we published this meta-analysis where we summarized the results from 10 studies, including more than 2,000 infants who had been randomized or pseudo-randomized to either air or 100% oxygen in the delivery room. And what we found was that there is an approximate 30% reduction in mortality in those who received air compared with 100% oxygen. So, consequently, ILCOR changed their guidelines in 2010, stated that in term infants receiving resuscitation at birth with positive pressure ventilation, it is best to begin with air rather than 100% oxygen. So the world map changed and looked something like this. And now babies who were resuscitated had this more physiological normalization of PO2. We avoided this enormous PO2 peak, as I showed you. So resuscitation with air reduces mortality, probably because of less oxygen toxicity. And it also opened up for the introduction of new resuscitation programs applying air instead of 100% oxygen, as for instance, the Helping Babies Breathe program. But there was and still is practice without evidence regarding, for instance, premature infants. We don't know the optimal initial FiO2, and we don't know the optimal way to titrate FiO2 versus saturation to achieve the optimal saturation the first minutes of life. So, what about preterm infants? Well, in 2010, ILCOR stated that because many preterm babies less than 32 weeks gestation will not reach target saturations in air, blended oxygen and air may be given judiciously and ideally guided by pulse oximetry. And in 2020, they specified this more and stated that one should start with 21 to 30% oxygen for all preterm infants less than 35 weeks. Now, the European consensus guidelines on RDS, published in 2019, says that oxygen should be controlled by using a blender and that an initial FiO2 of 30% is appropriate for babies less than 28 weeks gestation, and 21 to 30% for those between 28 to 31 weeks, and adjustments should be guided by pulse oximetry. What about moderate and late preterm infants? Well, we very recently published a survey of clinical practice in 20 countries, and this was quite recent data. We collected answers between October 2020 and March 2021, and we got almost 700 respondents from high and middle income countries. So these are babies between 32 and 36 weeks. And here we have the countries who answered. You see that from the Gulf area, Oman participated in this study. So the first question was availability of oxygen blenders in the delivery room and operating theater. And you can see that it was not a big difference between high and middle income countries. Approximately 70% or 2/3 at least had these blenders. What about pulse oximetry? Again, it was no big difference between high and middle income countries. Approximately 90% have access to pulse oximetry in the delivery room and operating theater. And most of those who, big majority of those who replied, said that they start with either room air or 30% oxygen. Only 5 and 2% start with 100% oxygen, probably because they don't have blenders, I guess. An important question is how saturation should develop optimally. And this is an article I published now 15 years ago in Journal of Pediatrics, where I put together a number of studies in this field. And you see that oxygen saturation starts low here at 1-2 minutes and increases gradually and took approximately, according to these data, approximately 4 minutes to reach a saturation of 80%. But then some years later, the so-called Dawson curves were published, where Jennifer Dawson and co-workers, they had collected data from a number of babies with different gestation ages. And here you can see how the saturation develops in babies 37 weeks and above. And here is the 50 percentile, and you see there's enormous variation between the third percentile down here and the 97th percentile up here. But you also see that at 1 minute, most of the babies start low and then gradually increases. So according to these data, it takes 2.5 minutes to reach a saturation of 80%. And for all babies, it took 3 minutes. Between 32 and 36 weeks, it takes 3.2 minutes to reach a saturation of 80%. And for those less than 32 weeks, according to these curves, it takes in median 3.6 minutes to reach a saturation of 80%. Now, those data were published before late clamping was practiced. And this is a study from Nepal by Kisi and co-workers showing that if you practice late cord clamping, you see that the saturation is higher already at 1 minute of age. And this seems to be the case for the first 5 to 10 minutes after birth. And also a study from Spain, from Max Vento's group, shows the same. This is a very recent study. And this is compared with the Dawson nomograms. And what you see here is that if you practice delayed cord clamping, instead of 2.5 minutes, it takes 1.1 minute to reach a saturation of 80%. And Max Vento and his group, they have also shown that the saturation is dependent on whether the baby is on CPAP or not. So if the baby is on CPAP, the saturation increases faster, the green line here, compared with the Dawson data. And also a sex difference, girls reaches a saturation of 80% earlier than boys, 4.8 minutes versus 5.7 minutes. So there's a number of factors that seems to influence how the saturation increases. So what about the very low birth weight infants and the immature infants? Should we ventilate these babies with an initial high or a low FiO2? Well, we have carried out several meta-analyses in this field, and I will show you data from one of these where we compared outcome in babies less than 32 weeks who had been either resuscitated in the delivery room with a high FiO2, 60 to 100% oxygen, versus a low FiO2, 21 to 30% oxygen. So this is data many of you have seen before, but regarding the primary outcome, hospital death, there was absolutely no difference whether you start high or low. And also for secondary outcomes as BPD, severe intraventricular hemorrhage, severe ROP, necrotizing enterocolitis, or PDA, there was no difference whether you start high or low in the delivery room in these babies. And then in 2007, the so-called torpedo trial was published with a principal investigator, Julie Owe from Sydney. In this study, infants less than 32 weeks were randomized to receive air or 100% oxygen if they needed positive pressure ventilation in the delivery room. And we didn't find any difference in mortality when we looked at all babies. However, when we analyzed specifically results from babies less than 28 weeks, we found that those who had been started with air had a significantly higher mortality than those who had been started with 100% oxygen. Relative risk 3.9, as you can see here. And we also found that those babies who had reached a saturation of 80% or more within 5 minutes, they had a 50% reduction in primary outcome, which was death or disability, compared to those who did not reach a saturation of 80% within 5 minutes. And those babies who didn't reach a saturation of 80% also had more severe intraventricular hemorrhage compared to those who had reached a saturation of 85%. And when we did a follow-up of these babies 2 years later, we saw that the cognitive score was significantly higher in those who had reached a saturation of 80%. It's 5 points higher. This is how babies in OI's cohort, this is not only from the torpedo trial, it's actually from more than 700 babies she and her cohorts have followed. And here you see babies less than 29 weeks were started with an FiO2 of 0.3. They start here low, approximately a little bit above 50%, but you see this gradual increase in saturation. And these babies, they need 6 minutes to reach in median or in mean to reach a saturation of 80%. So it indicates that maybe it's a little bit too slow. So if you start with 90 to 100% oxygen, yeah, then it takes in mean 3.6 minutes to reach a saturation of 80%. So here I compared 30% versus 90 to 100% oxygen, and you see that those who receive 90 to 100%, they have a higher saturation, which is not surprising. So the question is then, should we start with a low FiO2 and titrate up? Or should we start with a high FiO2 titrate down if it's needed? It seems that immature infants, at least immature rabbits, they need some extra oxygen in order to open the glottis. And without an open glottis, it's not possible to ventilate these babies. So perhaps the most immature babies would need a dash of oxygen. If that is the case, this should be as low and brief as possible, but we don't know what is the optimal. But in order to answer this question, Decker and co-workers from the Netherlands, they randomized babies 29 weeks or less to receive either 30% oxygen or 100% oxygen. And here they had a system where they titrated FiO2 according to the saturation. So what I found was that if you initiate stabilization of preterm infants at birth with 100% oxygen, they had a higher minute volume, they had an improved oxygenation, and a shorter duration of mask ventilation as compared to 30% oxygen, without increasing the risk for hyperoxia or oxidative stress. So this is, of course, very promising, but I think it's important to underline that this is a very small study, totally only 44 infants. And we have almost 1,000 babies in our cohort. Here I have shown how the saturation develops in this Decker cohort. So here, the orange here is babies started with 30% oxygen. You see they start lower than 40% saturation. And here, babies started with 100% oxygen. They start a little bit above 50%. So for these babies started with 100% oxygen, it takes 4 minutes to reach saturation of 80%. And for those who started with 30% oxygen, it takes between 5 and 6 minutes. So again, this indicates that maybe these babies need a little bit more than 30% oxygen. So what I've done now is that I'm comparing the development of the saturation in the OA babies to 9 weeks or less. So here's 30%. And what you see that is that the DECA baby, they start much lower than the OA baby, in spite of the fact that both start with 30% oxygen. So the DECA baby, they need 5 minutes to catch up with the OA babies. And here I have compared the OA baby, the red here, with the DECA babies who received 90 to 100% oxygen. Again, the DECA baby, they starts much lower, and it takes 4 minutes to catch up with the OA babies. So here I put all the 4 curves together, and I think this indicates and perhaps tells us that more important than starting with a high FiO2 is how you titrate the FiO2 according to saturation, because we want to start as low as possible. We don't want to start with 100% oxygen if it's not absolutely needed, because we know that this may trigger adverse effects. Well, so maybe 30% is not optimal for these babies, maybe 40% or 60% oxygen. And this we want to test out in a new study, Torpedo 3060. And I'm sure that if any one of you want to join that, you can contact, for instance, Rebecca Brown or me. And then I want to talk about the impact of the heart rate and the saturation. We very recently published this study, the so-called BRADIPREM study, where we were data from 700 babies less than 32 weeks. And we looked at outcome in babies who had no bradycardia, defined as a heart rate above 100 or above the first 10 minutes of life, versus transient bradycardia, heart rate below 100 beats per minute for less than 2 minutes, or prolonged bradycardia, heart rate below 100 beats per minute for 2 minutes or more. So here we have some infant characteristics, and you see babies gestation age typical 27 weeks, and birth weight less than 1,000 grams in mean. So what we found here was that mortality seems to increase with increasing duration of bradycardia, which probably not so surprising. So, and here we have carried out the meta-analysis of the studies we have combined in this BRADIPREM analysis, and you see that if you have prolonged bradycardia, mortality increase odds ratio is 3.49. This is highly significant. So here we have compared the effect of bradycardia with a satisfactory development of saturation versus a reference group, those who had no bradycardia and had a saturation of 80% within 5 minutes. So what you see here, a prolonged bradycardia, even if the saturation develops satisfactorily, increases risk for mortality odds ratio here 10.2. However, if the saturation is less than 80% at 5 minutes, transient bradycardia increases risk of mortality 8.2 times, and the combination of prolonged bradycardia and a low saturation the first 5 minutes increases the odds ratio almost 20-fold, odds ratio 18.6. So this tells us that the combination of low saturation and bradycardia is not a good sign for outcome. So what should we do? Well, we should target saturation or 80% within 5 minutes. We are quite sure that supplemental oxygen is needed in most immature infants, less than 28 weeks gestation. But if they need oxygen, it should, in case, be given as low and brief as possible. It is important to avoid bradycardia, and the combination of bradycardia and not reaching saturation target of 80% within 5 minutes increases mortality. So I'd like to underline that if you use supplemental oxygen, even very brief, this may lead to increased oxidative stress, inflammation, genomic changes, reduced DNA repair, cell growth inhibition, and long-term effects may also induce epigenetic changes, as were shown in animal studies. So what we recommend, but I don't say that we know the final answer, but we recommend so far that we should start low, for instance with 30% oxygen, and titrate up according to the saturation and the clinical response, which should be heart rate, and reach the target for saturation and the heart rate within 5 minutes. And then I'd just like to close with showing some very interesting data recently published in July by a Finnish group, Rantakari and coworkers. They had saturation values and arterial blood gases and FiO2 from 73 Elgins, gestation age in mean 26 weeks. And they followed them the first 3 postnatal days. And they looked at white matter injury by MRI and cortical injury by so-called magnetoencephalography. And what they found was that those babies who had a white matter injury, they had more often a saturation less than 90%. And fewer of the babies had a saturation above 98%. However, for those babies who had a cortical injury, it was the opposite. They had less babies with a saturation of 90% and more babies with a saturation of more than 98%. So one conclusion from this study is that lower saturation PO2 levels and higher FO2 need during the first 3 days of life in these small babies are associated with later white matter abnormalities and adverse neurodevelopment. I didn't show you those data. Infants with abnormal cortical function have higher early saturation and PO2 levels than the infants with more favorable cortical outcomes. So these results indicate that brain structures, white matter, are more vulnerable to hypoxia, whereas others, such as cortical areas, are more sensitive to hyperoxia. Well, of course, these data have to be confirmed in other studies, but they emphasize the importance of maintaining strict saturation targets during the early postnatal period. And it also makes this field much more complicated because it may indicate that some areas of the brain need a higher saturation and other areas would need a lower saturation. Makes it much more complicated in the future. So what should we do in the delivery room? Well, between 29 and 34 weeks, start with 21 to 30% oxygen. Babies 28 weeks or less, we think we should start with at least 30% oxygen. And here are some the nomograms you can follow and reach a saturation of 80 to 85% within 5 minutes. Well, if you need chest compression, I didn't have time to go into that. We still recommend to start with 100% oxygen. But as soon as you have established circulation, wean quickly to 21% oxygen, especially in term babies without lung disease. Here are some references for those who are interested. I would like to thank my distinguished collaborators, Max Vento, Satyan Laxmin Rushma, Julie Owie, and Vishal Kapadia. Thank you so much for your attention.
Thank you very much, Dr. Rolla, for a great presentation. I'm sure there are going to be a lot of questions. And this is a really important topic for oxygen management of extremely low birth weight or low birth weight infants. We keep the theme of improving the outcome of babies who are premature. And it's my pleasure and honor to introduce the next speaker of this session, Dr. Raymond Stetson. Dr. Raymond is an assistant professor of pediatrics at Mayo Clinic, Rochester, Minnesota, in USA. Dr. Raymond completed his fellowship in the neonatal perinatal medicine at Mayo Clinic School of Graduate Medical Education, Mayo Clinic College of Medicine. He has many important clinical focus areas, which include the care of babies under 22 weeks and congenital anomalies, metabolic and genetic disorders, and acquired conditions, including the hypoxic ischemic encephalopathy. He also involved in many quality improvement projects to improve the care for hospitalized newborn. Dr. Raymond will talk to us about non-invasive ventilation. Please join me in welcome Dr. Raymond Stetson.
Hi, I'm Dr. Ray Stetson. I'm a senior associate consultant, assistant professor of pediatrics, and clinical neonatologist at the Mayo Clinic in Rochester, Minnesota, in the United States of America. Today we're going to be discussing non-invasive ventilation in newborns, a truly hot topic in neonatal medicine for nearly 50 years. I don't have any financial disclosures or conflicts of interest pertinent to this topic. However, we will be discussing several FDA-approved and non-FDA-approved devices and the use of non-invasive ventilation and surfactant administration in newborns. We'll have three primary learning objectives. First, we'll review the historical context of non-invasive ventilation use in newborns with respiratory distress syndrome. Second, we'll discuss non-invasive ventilation devices, modalities, and their effects on neonatal outcomes. Finally, we're going to review trends in the use of non-invasive ventilation in newborns and trends in neonatal outcomes. Infants with respiratory distress syndrome have insufficient surfactant, which leads to atelectasis, decreased functional residual capacity, and decreased lung compliance. In non-invasive ventilation strategies, this is treated with positive airway pressure, which helps to overcome atelectasis and increase functional residual capacity to increase the infant's ability to oxygenate and ventilate. The first use of endotracheal continuous positive airway pressure was described in 1971 by George Gregory and colleagues at the University of California, San Francisco. They reported a case series of 18 infants with respiratory distress syndrome treated with continuous positive airway pressure delivered by an endotracheal tube with reports of improved oxygenation and survival. In the same study, Gregory and colleagues also described the use of the first non-invasive delivery of CPAP. This was accomplished by use of a device that would go on to be called the Gregory box. They used this Gregory box to support 2 infants, and this device consisted of a chamber that was closed around the infant's head and sealed around their neck. This allowed generation of positive airway pressure and installation of supplemental oxygen. Dunn and others would go on to report improved survival in case series of infants with respiratory distress syndrome using similar devices to the Gregory box. In the following years, further innovation of devices to non-invasively deliver CPAP to infants with respiratory distress syndrome were developed, eventually leading to the face masks, nasal prongs, and nasal masks utilized in modern neonatal practices. In the late 1980s, there was a growing level of interest in identifying exposures and treatment modalities associated with improved neonatal outcomes for premature infants, including increased survival to NICU discharge, and decreased morbidity for conditions such as bronchopulmonary dysplasia. In 1987, Avery and colleagues performed a survey of 8 large neonatal intensive care units, with 7 of the units located in the United States and 1 unit located in Canada. They sought to determine these factors related to better infant survival for premature infants and decreased morbidities. This study included over 1,600 infants with birth weights between 700 and 1,500 grams. Avery noted that center number 3 in this survey, which corresponded to Columbia University, had both one of the highest rates of survival to NICU discharge as well as the lowest rate of bronchopulmonary dysplasia reported of any of the 8 centers which were surveyed. Bronchopulmonary dysplasia was defined in this study as oxygen dependence at 28 days of age. Compared to the other centers, Columbia had much higher usage rates of non-invasive ventilation, which they supplied by nasal bubble CPAP. They also had much lower rates of mechanical ventilation. This sparked an era of innovation and interest in utilizing non-invasive ventilation strategies in the care of premature infants with respiratory distress syndrome. Nasal CPAP can be administered non-invasively to infants, either via bubble CPAP circuits or ventilator-driven CPAP circuits. In either case, the continuous positive airway pressure is delivered to the upper airways through tubing and interfaces with the infant's nares, either through nasal cannula or nasal masks. Ventilator-driven CPAP tends to deliver a more consistent level of CPAP, while bubble CPAP tends to generate variable descending pressure, sometimes called the noise of bubble CPAP. Each system has its benefits and drawbacks. Bubble CPAP systems can be more cost-effective to implement, and many take up smaller footprints in the infant's care room when compared to ventilator-driven CPAP. Ventilators may offer clinicians more versatility in ventilation options. This includes the ability of some systems to also perform nasal intermittent positive pressure ventilation. Additionally, if infants' respiratory status decompensates and they require intubation, the same ventilator can often be used to deliver mechanical ventilation. Nasal intermittent positive pressure ventilation is another non-invasive ventilation strategy available to support infants with respiratory distress syndrome. Nasal intermittent positive pressure ventilation involves providing a continuous positive airway pressure along with intermittent higher ventilator provided pressures or breaths. These additional intermittent breaths can either be synchronized to the patient's respiratory status or delivered asynchronously. A 2017 Cochrane review found that premature infants with respiratory distress syndrome who were extubated to nasal intermittent positive pressure ventilation rather than nasal CPAP had lower rates of reintubation. A concern arose following the development of nasal intermittent positive pressure ventilation that there may be more GI side effects related to asynchronous breaths being delivered when the infant's glottis was closed, causing distension of the esophagus and stomach. However, in this same 2017 Cochrane review, the researchers noted that there were similar rates reported in the literature of necrotizing enterocolitis, gastric perforation, or cessation of feeds due to abdominal distension in infants treated with either nasal intermittent positive pressure ventilation or nasal CPAP. Heated and humidified high-flow nasal cannula provide distending pressure to achieve non-invasive ventilation by delivering a set amount of gas flow and allowing variations in airway pressure. In neonatal practice, these flow rates typically range from 1 to 10 liters per minute. High-flow nasal cannula can be administered either with locally made systems, commercial high-flow nasal cannula with specific products, or by a subset of mechanical ventilators. High-flow nasal cannula systems have fluctuating airway pressure, and all systems require a pressure pop-off valve for patient safety. When the cannula are occluded, very high airway pressures can be recorded if the pressure pop-off valve is not in place. Wilkinson et al. Described an equation to estimate pharyngeal pressures based on high-flow nasal cannula flow rates and patient weights. They also described similar airway pressure measurements for patients treated with high-flow nasal cannula when their mouths were open versus when they were closed. Initially, high-flow nasal cannula was also thought to perhaps be a more cost-effective method of delivering non-invasive respiratory support to infants when compared to nasal CPAP. However, a recent study from Australian researchers found that high-flow nasal cannula systems in special care nurseries were actually more costly than systems that had nasal CPAP as the primary non-invasive ventilation support. However, approaches in systems that use high-flow nasal cannula with nasal CPAP backup were found to have similar cost effectiveness in this study to units that used just nasal CPAP. Nasal breakdown is also a concern for infants supported with non-invasive ventilation. Not only can nasal breakdown cause patients pain and discomfort, but if it progresses, it may limit the ability to continue use of non-invasive ventilation, and invasive ventilation may need to be pursued in order to allow healing of the nasal breakdown. Additionally, for a subset of patients with severe nasal breakdown, surgical repair may be required. A recent systematic review of 45 studies found that nasal injury is common in patients treated with non-invasive ventilation, with rates ranging from 20% to up to 100% depending on the study. Factors that make nasal injury more common include use of binasal prongs or patient gestational age less than 30 weeks, use of masks rather than prongs, nasal barriers, or high-flow nasal cannula rather than nasal prongs were all found to be protective against nasal injury in infants treated with non-invasive ventilation. Evidence is currently lacking to guide a consensus approach in weaning nasal CPAP. Nasal CPAP duration must be a balance between patient benefits, which include increased functional residual capacity and lung function, upper airway splinting for infants with airway malacia, and reduced caloric expenditure for work of breathing, with the potential adverse effects of nasal CPAP, which can include decreased venous return and cardiac function secondary to high thoracic pressures, abdominal distension and feeding intolerance, delayed oral feeding initiation, and nasal injury. Commonly, weaning timing is based on patient gestational age, work of breathing, supplemental oxygen needs, chest radiograph patterns, tolerance of empiric support weans, and sometimes patient weight. Additionally, there are various approaches to weaning CPAP support, which can include incremental decreases in the CPAP pressure versus cycling infants on and off CPAP support for gradually longer periods of time. In the early 2000s and 2010s, high-flow nasal cannula was emerging as a more common modality for non-invasive ventilation support of newborns with respiratory distress syndrome. However, there was evidence lacking on its efficacy compared to nasal CPAP in treating infants with respiratory distress syndrome. In 2016, Roberts and colleagues reported a large international randomized controlled trial of over 500 preterm infants who were greater than 28 weeks of postmenstrual age who had respiratory distress syndrome who were randomized to either primary treatment with nasal CPAP or high-flow nasal cannula. Of note, this randomization occurred immediately after delivery, and infants had not received surfactant therapy prior to randomization. The primary outcome of this study was treatment failure within 72 hours. This was defined as progression to nasal CPAP or intubation for the high-flow nasal cannula arm, or progression to intubation for the CPAP arm. Higher rates of treatment failure were observed in the high-flow nasal cannula arm of the study, with a trend towards higher rates of intubation in the study arm as well. The trial was actually stopped early by the Data and Safety Monitoring Committee due to the discrepancies in outcomes, with the CPAP arm having more favorable respiratory outcomes. As non-invasive ventilation techniques have increasingly been used to support infants with respiratory distress syndrome cared for in NICUs, investigators have been focused on optimal respiratory care for infants in the delivery room as well. In 2010, researchers from the Neonatal Research Network performed a trial dubbed the SUPPORT trial. This randomized multi-center trial included over 1,300 infants examining intubation and surfactant administration within the first hour of life versus initial respiratory support with nasal CPAP. Study subjects ranged from 24 to 27 and 6/7 weeks gestational age at enrollment. The investigators found that both study arms had similar rates of their combined primary outcome of death or bronchopulmonary dysplasia. Infants initially treated with nasal CPAP had lower rates of intubation, days of mechanical ventilation, or receipt of postnatal steroids for treatment of bronchopulmonary dysplasia. Researchers in the Australia-Asian Trial Network performed a similar study called the CPAP or intubation, also known as the COIN trial. In this study, over 600 infants were randomized to either delivery room nasal CPAP or intubation. Of note, unlike the support trial, infants in the intubation arm were not universally administered early surfactant per the COIN trial protocol. A non-significant trend towards lower rates of BPD or death at 36 weeks was noted in the CPAP arm. However, higher rates of pneumothorax were also noted in the CPAP arm. A trial conducted by the Vermont Oxford Network in the United States randomly assigned infants to one of 3 treatment arms. These included prophylactic surfactant administration and extubation to nasal CPAP, or primary support with nasal CPAP. There was no significant difference in this study between these 3 treatment arms for their primary outcome of bronchopulmonary dysplasia or death at 36 weeks. The South American Neocosur Network performed a trial comparing initial support with nasal CPAP versus oxygen hood, with a trend towards lower rates of bronchopulmonary dysplasia in the nasal CPAP arm of this study. Several strategies and techniques have been developed to administer surfactant to infants with respiratory distress without exposing infants to mechanical ventilation or minimizing the duration of mechanical ventilation exposure. The intubate surfactant extubation, also known as ensure technique, involves intubating infants, administering surfactant, and then extubating to non-invasive ventilation support. Techniques have also been developed, such as the less invasive surfactant administration, or LISA technique, to instill surfactant through a thin catheter while the infant is spontaneously breathing and avoid the need for endotracheal intubation. The LISA technique for surfactant administration is more widely used in Europe, the Middle East, Australia, and parts of Southeast Asia than compared to the United States. A 2018 survey of neonatologists practicing in the United States found that only 15% utilized the LISA technique in their clinical practice, and nearly half of these neonatologists were utilizing the LISA technique as part of a research study. Nebulized and atomized surfactant administration has been described in animal models as early as the 1990s. Several randomized clinical trials have been performed assessing the efficacy of aerosolized surfactant. The current Aerofact 2B trial is currently enrolling and comparing nasal CPAP alone versus nasal CPAP and aerosolized surfactant administration. Earlier this year, Hatch and colleagues reported on trends in initial respiratory support modalities for infants cared for in NICUs across the United States. Their study utilized 2 large databases and included over 250,000 subjects across over 350 NICUs. Their study period looked at the years 2008 to 2018. Over this 10-year period, a significant increase in the use of nasal intermittent positive pressure ventilation and nasal CPAP was noted, along with a concomitant decline in the use of mechanical ventilation. Overall rates of non-invasive ventilation support rose from 58% in 2008 to over 67% in 2018. Mechanical ventilation use during the same period declined from 22% in 2008 to 18.5% in 2018. In the same study, Hatch and his co-investigators found that the duration of positive pressure support increased during the study period by an average of 3.2 days per patient. This trend was noted in nearly all examined gestational age groups. Additionally, the trends of increased non-invasive ventilation support and declined use of mechanical ventilation were consistent across all examined gestational age groups. Even the youngest gestational age group of 23 to 25 weeks had an increase in non-invasive ventilation support of over 50% of the subjects. Hatch et al. Also looked at differences in the expected mechanical ventilation use based on 2008 practices and patient characteristics noted across the study period, and the observed mechanical ventilation use that they saw in their study. Based on these differences in observed to expected mechanical ventilation use, they noted that an estimated 29,700 fewer infants were exposed to mechanical ventilation, secondary to the changes in trends in increased non-invasive ventilation use and decreased mechanical ventilation use during the study epoch. This resulted in an estimated 142,000 fewer days of mechanical ventilation for patients during the study period. Despite the significant advances that have been made to respiratory management of premature infants with respiratory distress syndrome, both from non-invasive ventilation and invasive ventilation modalities, complications from respiratory distress and bronchopulmonary dysplasia still account for a large amount of the mortality observed in neonatal intensive care units. A recent cohort study found that in the first 2 weeks of life, nearly half of all deaths are secondary to respiratory distress syndrome. In the first month of life, respiratory distress syndrome still accounts for 43% of observed deaths in NICU infants. For infants hospitalized in NICUs for over 2 months, complications from bronchopulmonary dysplasia are the leading cause of death. This highlights that while we've made significant advances in the field of respiratory support for premature infants, this is still an area that needs more innovation and research. I think it's also important to remember that bronchopulmonary dysplasia affects more outcomes for premature infants than just their survival or respiratory status. In a retrospective cohort study utilizing NICHD Neonatal Research Network data from patients cared for from the years 2006 to 2010, Zhang and colleagues found an increased risk for neurodevelopmental impairment at 18 to 22 months for infants who received prolonged respiratory support. Infants who received only invasive respiratory support had the highest rate of neurodevelopmental impairment at 18 to 22 months at nearly 90%. This was followed by infants whose support was a mix of invasive and non-invasive support, who had a 26.1% rate of neurodevelopmental impairment at 18 to 22 months. Infants who only required non-invasive support had the best neurodevelopmental outcome in this study, with only 7.7% having neurodevelopmental impairment noted at 18 to 22 months. Despite the increased trend in usage of non-invasive ventilation support strategies, the decreased trend in the use of mechanical ventilation, and the increased use of surfactant therapy in the treatment of respiratory distress syndrome for infants, a recent cohort study of over 34,000 infants who were born between 22 and 28 weeks gestational age, with birth weights ranging from 400 to 1,500 grams, found stable to increasing rates of bronchopulmonary dysplasia. The study period ranged from 1992 to 2012. Further, a study of pulmonary function in children who had been born prematurely had similarly concerning findings. In this study, they examined the pulmonary function status at 8 years of age for children who had been born at less than 28 weeks of gestation. Surprisingly, it was the most modern epoch of children who actually had the worst pulmonary function at 8 years. This is despite the fact that this epoch of children was exposed to lower rates of mechanical ventilation and higher rates of non-invasive ventilation support. These findings highlight that bronchopulmonary dysplasia is a complex disease process and that we need to examine near-term, medium-term, and long-term outcomes when considering respiratory support management for these patients. Thank you for the invitation to present this very interesting subject in neonatal medicine. I'm including this slide to reference the papers discussed in this presentation. Additionally, each reference is included on the bottom of the slide where it is first mentioned. I look forward to your questions during our panel discussion.
Thank you very much, Dr. Stetson, for really a very informative and practical presentation. I'm sure we're going to have a lot of questions from the attendees. We're moving to the third presentation of this session. It's my pleasure to introduce again Dr. Ola Savastad. He's going to talk to us about delivery room management of the newborn. Dr. Ola.
Once again, thank you for this invitation. And my second lecture is about delivery room handling of the newborn. And here are my disclosures. And I put up 3 learning objectives for this lecture. First of all, it is to understand the newborn resuscitation algorithm. And I also want to discuss the effect of delayed cord clamping and also heat loss prevention and hypothermia therapy. Specifically, I would like at the end to talk about the so-called HELIX trial, which has created a huge debate about the hypothermia therapy in low-income countries. Well, talking about delivery room management or handling, there are a number of topics we could cover, and I listed many of them here. And I don't have time to penetrate these in depth during these 30 years, but I will touch many of these. So when we discuss delivery room management, we also very often talk about the golden minute or the golden minutes. And the reason for that is that what we do with, for instance, asphyxiated newborn infants in the delivery room, and here I listed some of the procedures we are applying to these babies. So what we do during these minutes may be very important for the outcome, the rest of the life for these babies. Of course, postnatal care is also important, and also antenatal care. And I will mention a few maternal and antenatal factors we should consider. First of all, we know that perinatal death, not only perinatal mortality, but also newborn and infant mortality increases with increasing BMI. So it's important to inform young women and even girls that they should keep their BMI within normal ranges before they become pregnant. We also know that antenatal steroids, in the case of threatened premature labor, may reduce mortality. And here are data from the European database eNewborn, where we have almost 40,000 babies born between 22 and 32 weeks of gestation. And what you can see here is that a complete course of antenatal steroids reduces mortality with more than 50%, but even an incomplete course does the same. So this is important to remember. Now, of course, there's a new discussion about the effect of antenatal steroids in low and middle income countries, and it may not be as efficient as we have believed up to now, but that's another discussion. C-section rate is also important for the outcome, and it has been shown that if the C-section rate in a country exceeds approximately 10%, there's no or very little effect on mortality. So it seems that perhaps the optimal C-section rate is between 10 and 15 or maybe up to 20%. This is important because we know that many countries in this world have a very high C-section rate. And we know that it matters because if a baby is born before 40 weeks, morbidity increases. And this is illustrated here by looking at so-called serious respiratory morbidity. You see at 37 weeks, C-section versus vaginal is extremely high. And even up to 39 weeks, C-section versus vaginal delivery increases morbidity. So I think it is important that we keep the C-section rate at reasonable level. So what is the need of resuscitation? Again, I will show you data from the European database in newborn, and here you see we show that the smallest babies, the immature babies, almost 100% of these needs resuscitation at birth, and then it drops to still more than 50% for 32 weeks. But we have to distinguish between basic resuscitation and advanced resuscitation. In basic resuscitation, we define as the use of bag and mask ventilation and oxygen if needed, and you see that very few of the immature babies need basic resuscitation, but more 32 weeks need that. But when it comes to advanced resuscitation, we see that most of the immature babies would need advanced resuscitation. And this is defined as bag and mask plus oxygenation, intubation, chest compressions, and adrenaline if needed. And is this of interest? Yes, it is, because we have shown that mortality is not increased in babies in need of basic resuscitation. But as soon as they need advanced resuscitation, we see that mortality is increased almost twofold. So this is the ILCOR neonatal resuscitation algorithm. And this is from the guidelines from 2010. And in 2010, the so-called golden minute was introduced here. Before that, they had timed every event by 30 seconds intervals, but now it was simplified. But the golden minute was introduced. But the question is, when is the golden minute? And ILCOR didn't define that. And when you look into the literature or ask people, you see that there are different practices when you start a clock. I think we should agree on this definition. The baby is born as soon as the whole baby is out, and then we start the clock. And this is, of course, extremely important to agree upon when we now talk about the golden minute, the first 60 seconds after birth. And we also do the APGAR scoring at 1 minute and 5 minutes. So we have to know what we are doing. Is it realistic to achieve this, the golden minute? Well, we recently published this small review about some studies that had been published using the so-called Helping Babies Breathe algorithm. And you see this study from Tanzania, published 4 years ago. You see that time to obtain the first ventilation with bag mask was in mean 134 seconds. That's 2 minutes and 14 seconds, way beyond the golden minute. This study here from Uganda, they're better, very close to golden minute, 68 seconds, and also from Nepal, 71 seconds. And again, the same group from Tanzania, 109 seconds. So they're not able to follow the algorithm of Helping Babies Breathe, but it is possible, at least for most or many babies, to start ventilation within the first minute of life. So if we go back to the ILCOR recommendations, the first 30 seconds, the baby should be dried, kept warm. It should be wrapped into plastic if it's less than 28 weeks gestation, and stimulated to breathe if that is needed. We know that 15% of all babies would need stimulation to start breathing. The airway should be positioned correctly, and the heart rate and breathing rate should be recorded. If the baby needs respiratory support, this should be established within 60 seconds. And if you have a pulse oximeter, it should be on within the first minute of life. There were some changes in the algorithm from 2010 to 2015. They're revised every fifth year. And you see here now that the golden minute in 2010, it was split up in two halves, each 30 seconds. Now it's only one line here. And then this new temperature line was introduced, reminding us how important it is to keep the baby warm during the recitation. So we published a review of the 2015 ILCOR guidelines together with Nicky Roberts and Max Vento. We published that, and we were a little bit disappointed regarding these guidelines because we found they were not so complete. We needed to remember the 2010 recommendations because they were not repeated in 2015. And these guidelines also introduced ECG and suggested to use ECG for heart rate assessment instead of stethoscopy. CPAP for term infants was recommended, but it was not evidence-based at that time, at least. And we were also worried about using a combination of plastic wrapping and thermal mattresses for the most immature babies, because that may induce overheating. And ILCOR also recommended the use of therapeutic hypothermia in low resource settings. But in our opinion, this was not evidence-based. In addition, the use of passive cooling by ice packs may result in overcooling. So we were not so satisfied with the 2015 ILCOR guidelines. Now, in 2020, a revised version came out. And again, together with Nicky Roberts and Max Vento, we reviewed this. And what you can see here is that there are one new recommendation and 5 procedures had been changed. So the new recommendation was that it was recommended to do briefing and debriefing after resuscitation. And then there was some modifications regarding handling of non-vigorous delivered through babies through meconium amniotic fluid. Sustained inflation was not recommended in preterm babies, and there were some adjustments regarding epinephrine. For instance, if there was no intravascular access, it was now again recommended to use the intratracheal route, but then with a higher dose. And regarding vascular access, umbilical venous catheterization is recommended as a primary mode, but if you don't have access there, the intraosseous route is a feasible alternative. What also was new was that if there was no return of spontaneous circulation within 20 minutes, then you should discuss or ILCOR suggests that you should start discussing of discontinuing resuscitative efforts. In the old guidelines, you remember that they said after 10 minutes you could stop or consider to stop. And I think the present guidelines on this issue is much better. But what you also can see that all these recommendations are based on none or very weak or low evidence. So this indicates that there's a lot of work to do before we really have evidence-based recommendations. A few words about heart rate assessment at birth. We know that heart rate by auscultation is inaccurate and underestimates the heart rate obtained by ECG. But to compensate for that, together with Roger Soll, we suggested that if the heart rate is counted 10 instead of 6 seconds, much of this inaccuracy could be eliminated. We also know that a reliable heart rate is obtained earlier with ECG than with pulse oximetry. In one study, the difference was 84 seconds. But we also know that quite a few of the ECG signals are excluded due to technical problems, and we also have a problem with so-called pulseless electrical activity in animal models. It has been shown that a very high percentage of the signals are PA. So we hope for new devices, and we know that there are new devices under development, for instance, based on Bluetooth technology and other technologies. But in 2016, Roger Sull and I, we declared that we think that auscultation is still the gold standard for auscultation for assessment of the heart rate at birth, and I think that is still valid. So, cord clamping. Today, most international organizations in this field, they recommend delayed cord clamping, especially in preterm babies, and they recommend about 60 seconds. You see some variation between the different declarations, and some said at least you should wait 60 seconds. And the reason for that is that within 60 seconds, approximately 70% of the blood from the placenta, which is transfused to the baby, has reached the baby. So there's not so much to gain if we wait another minute, for instance. Now, of course, we talk about physiological cord clamping. That means that you should ventilate before you cut the cord. And here is a study from Stuart Hooper, an animal study from Stuart Hooper in Melbourne, showing what happens if you clamp the cord before the onset of ventilation. You see arterial blood pressure goes up like this. Carotid arterial blood flow also increases. By contrast, if you clamp the cord after ventilation has been initiated, you see that there's a very smooth, there's absolutely no increase in arterial blood pressure, and also carotid arterial blood flow is very stable. Is there any risk for delayed cord clamping as overtransfusion, polycythemia, jaundice, hypothermia, persistent pulmonary hypertension, delayed resuscitation? Well, recently Bruckner and co-workers summarized this, and they recommend that one should practice delayed cord clamping in healthy term infants for at least 60 seconds in high environments units, and for at least 180 seconds in limited resource environments. And they also tell that delayed cord clamping reduces incidence of anemia and iron deficiency, improves hemodynamic parameters, and there is no evidence that delayed cord clamping results in higher rates of phototherapy. We know from studies that, of course, there is an increased incidence of polycythemia, but it's probably most often asymptomatic. Regarding growth retarded newborns and monochorionic twins, we need more evidence before we can give recommendations for delayed cord clamping or not. So here we have summarized some of the differences between immediate cord clamping and delayed or deferred cord clamping. Regarding oxygenation, you see that the saturation are higher the first minutes of life with delayed cord clamping. You see preductal saturations are lower with immediate cord clamping. As you can see here, we try to illustrate here. What about cord milking? For instance, if you cut the cord about 25 centimeters from the umbilicus, and this should be done within 30 seconds after birth, and then you should milk the cord at a speed of 10 centimeters per second. Well, Katere and co-workers have published data from immature babies showing that cord milking in these babies compared with delayed cord clamping increases severe intraventricular hemorrhage, 4, 5, 6-fold. So it's a dramatic increase in severe intraventricular hemorrhage. So what happens when you milk the cord? You increase the venous return to the right atrium, and blood enters the foraminal valley and the aorta up to the brain. And if you have pulmonary vasoconstriction and there is lack of cerebral autoregulation, and there is a right to left ductal shunt, this may result in fluctuations in flow. And we know that an immature brain has a very fragile germinal matrix. This may lead to intraventricular hemorrhage. Few words about the chest compressions and adrenaline. And this, which we're about to publish, showing that if you give epinephrine during resuscitation, the dosage is 0.003 milligram per kilo, and you flush with only 1 ml of saline, 43% receives return of spontaneous circulation after 1 dose, and the median time to get return of spontaneous circulation is 95 seconds. If you flush with 2.5 ml, 80% receives spontaneous circulation after first dose, and median time is 72 seconds. But if you flush with 10 ml, 3 milliliter per kilo, 90% get back the spontaneous circulation after first dose, and the median time is now 39 seconds. So we recommend to flush with more than 1 milliliter, and probably you should use approximately 3 ml per kilo by flushing. How should you oxygenate the baby during chest compressions? Which FiO2 should be applied, and how should we wean if you use 100% oxygen during chest compression? Should you wean rapidly or gradually when return of spontaneous circulation is achieved? Well, if you look at the recommendation by the NRP in US, they state that it may be reasonable to increase inspired oxygen to 100% if there was no response to positive pressure ventilation with lower concentrations. And once return of spontaneous circulation is achieved, the supplemental oxygen concentration may be decreased to target the physiological level based on pulse oximetry to reduce the risks associated with hyperoxia. Now, very recently, Sankaran in Satya and Lakshman Rushima's group in US, they tested this out in animal studies, and what they found was that if you wean immediate to air, cerebral oxygen delivery reaches the target very quickly, within approximately 1 minute. However, if you wean gradually as recommended, you see that there is a very high oxygen delivery for up to almost 15-30 minutes. And it has been shown that even if you use 100% oxygen during chest compressions, the oxygen saturation and PO2s are low. So we think that it is important to wean quickly to room air as soon as spontaneous circulation is achieved. Heat loss. As I mentioned, Ilka now emphasizes the importance of maintaining the temperature. And for immature babies, in order to prevent heat loss, the babies are covered with an occlusive wrap or put into plastic bags immediately after birth without drying them. And this reduces the incidence of hypothermia and hopefully result in decreased morbidity and mortality. However, a systematic review, a Cochrane review, which was published by McCall and co-workers in 2018, 3 years ago, didn't find any difference regarding major brain injury, whether you wrap the babies into plastic or not. And when they looked at mortality, again, there was no effect of wrapping into plastic. So this is, of course, disappointing. Still, we think it is important to maintain the temperature. Very recently, this study regarding early kangaroo mother care for low birth weight infants was published in New England Journal of Medicine. And it shows that early kangaroo mother care reduces mortality, and the number needed to treat to prevent one neonatal death is 27. And this study was carried out in Ghana, India, Malawi, Nigeria, and Tanzania. So this is highly recommendable. Then I will end talking about the so-called HELIX trial, which is a hypothermia therapy trial in 3 countries, India, Sri Lanka, and Bangladesh. And this study was published last week, and has created a lot of debate already. So in this study, babies with low and moderate hypoxic ischemic encephalopathy, more than 36 weeks or 1.8 kilo, were randomized to receive hypothermia therapy or controls. And you can see that they were quite successful in reducing the body temperature to the goal of 33.5. And after 72 hours, the babies were rewarmed, and you see they were very successful in this procedure. However, when they looked at the outcome of these babies at the age of 18 to 22 months, what I found was that mortality was significantly higher in the hypothermia treated babies, 42% versus 31%. And this, of course, created a lot of discussion. Here is a Kaplan-Meier plot demonstrating basically the same, that babies who were treated with hypothermia, they died earlier and they had a higher mortality. And so here's the summary of all the centers, the data from the HELIX trial. And you see that if you cool the baby, you have a higher mortality. So the risk of surviving is 50% higher if you don't cool the baby, if you practice what they call usual care. Now, this has created a lot of discussion. And very recently, this paper came out with the title, The Rise and Fall of Therapeutic Hypothermia in Low-Resource Settings, Lessons from the HELIX Trial. Because these data from the HELIX trial, of course, represent a threat to the use of hypothermia in many low-income countries in Africa and other places around the world. So in this article, the authors were quite harsh and stating that generation of high-quality research data alone are not sufficient. It is important that low and middle-income countries clinicians have the necessary skills to interpret these data and use it in their clinical practice without being influenced by industry lobbying or stakeholders with vested interests. I took myself part in a Zoom meeting about this study from South Africa 2 weeks ago, and I think this study has really created a lot of debate. So this is, if you look at the data before the HELIX trial, it shows that it favors, this is a meta-analysis, it's all the studies, it favors cooling. So why does the helix trial show the opposite? I think the subject is not settled yet, but I think also it illustrates that you cannot translate research results from high-income countries to low-income countries because they have a different situation and the babies are different. So I think that is an important lesson. So, in a summary, we recently published this article about delivery room management of asphyxiated term and near-term infants. And here we have listed a number of the topics which are of interest for resuscitation and delivery room handling. I don't have time to go through all this. What we have tried to do is that we have tried to specify differences between low resource settings and high resource settings regarding all these topics. So if you're interested, you can read this. Of course, there are a lot we can discuss here. And when I'm rereading this, although this is a very, very new article, I see that maybe I would have phrased some of the recommendations differently already. So here are the references you can read for those who are interested. These are quite recent articles we have published. So with this, I would like to thank you for your attention and
Thank you very much, Dr. Ola and Dr. Raymond, for a really very informative session. We have received some questions from the audience, and we're going to start with some questions. Dr. Janine?
Okay. So the first question, Dr. Ola, about the oxygen delivery. Is many times it happened that the babies, especially I'm talking about less than 27 week or 28 week, that they automatically started with 50 to 60%, and then they wean it up down. Most of the time it is happening is still in the delivery rooms. And I know your recommendation, that NRB recommendation, to start with 30 maximum. But this is, I think, a physician anxiety or the nurse's anxiety. Do you have any recommendation how to tackle that?
I had a little bit problems hearing clearly, but the question was that you start with high FiO2 or high flow?
Yeah,
oxygen?
high FiO2.
Yeah.
Most of the time in the delivery room, when the baby delivered 27 weeks, is automatically like 60-70%, and then the wean.
Yeah. Well, of course, this is the big question to discuss now, and we don't have a final answer. But according to the survey I showed you, most of those who responded, almost 700, responded to our questions regarding not the most immature babies, but from 32 to 36 weeks. They do not start with a high FO2. Most of them start with 30% or air, a few with 40% oxygen. But I guess that if you don't have a blender, you are facing a dilemma. And there has been studies from Thailand, for instance, showing that with a certain flow, you can ascertain that you don't get too high FiO2. So I'm sorry I cannot give you any more
Sure.
complete answer to
Yeah,
this.
and related to this question, Dr. Ola, that many times we notice that when we are doing procedures, for example, we bring the baby on the CPAP, baby is doing fine, but they have to put the line at that time. Let's say baby start a little bit desetting the none of the oxygen, which is also to me is not ideal, but it is happening.
Yeah, I think your question is very important because it also illustrates how much we don't know in this field. Because I was talking about the first 5-10 minutes, and we don't have data or not very firm data beyond that. So what I can say is that during the first 5 minutes, we want to aim at a target of 80-85% oxygen. What happens after 15 minutes or 20 minutes if the baby needs more oxygen, we don't know. I mean, then we have to judge on our clinical experience and practice.
I have a question for Dr. Raymond. What is the maximum PIP you use for non-invasive nasal ventilation? And is there a risk of having intestinal perforation when you use high PIP or high P?
Yeah, that's a great question. I don't know if there is good guidance on the highest PIP use. I can say in our practice, we'll typically, when we're using non-invasive positive pressure ventilation, we use it asynchronously with the baby's respiratory status, and typically we'll go anywhere from 10 to 20 centimeters of water above what the PEEP is. In that Cochrane review I pointed to from 2017, they didn't show any difference in the rate of gastric perforation for an IPPV in the studies they reviewed versus nasal CPAP. So I think that is somewhat reassuring there.
Dr. Ola, there's a question about the delay in picking up the saturation in the first 60 seconds after birth. What should we do with this in this case when the pulse oximeter does not pick up the saturation? What kind of oxygen we should use?
Yeah, I mean that is a very relevant question, and the problem with pulse oximetry is, of course, that the signal is you're receiving a good signal quite late when you're talking about the first gold minute or first minutes of life. And the only thing I can say is that, as far as I know, there is in the pipeline pulse oximeters with a much faster response. And so I've seen some preliminary data showing that you may have a good signal already, maybe within the first minute. So, but I don't have any personal experience with that.
There's a question about stopping resuscitation. As you mentioned, the 2015 NRP suggested to stop resuscitation if there's asystole after 10 minutes. They said it's reasonable to stop resuscitation after 10 minutes. Now, this is the reverse of the 2020 guidelines, where they say that you should continue for 20 minutes. The question is, what happens if you still have bradycardia, but not asystole, after 20 minutes of life, and the babies continue to have a low heart rate, but there is a detectable heart rate? What should the team do?
I think the most data are about if you don't have any heart. For instance, the previous recommendations stopping after 10 minutes was based on studies where you didn't have any heartbeats the first 10 minutes. As soon as you have a heartbeat, let's say the first 10 minutes, we don't have data. I have myself many times been in this dilemma, and you have baby's bradycardic, and I've continued to do, for instance, chest compressions beyond 20 minutes. But of course, I don't think we have much evidence for that. And again, it's a clinical judgment. And that's why I like the 2020 guidelines better, because they suggest that we should discuss when you have reached 20 minutes and you don't have um, obtained the return of spontaneous circulation. And this indicates that we don't know. I mean, here is an area where we don't have knowledge, and we need to fill this gap, I think.
Thank you. Do you have any questions?
Yeah, I have 2-3 questions. First for Ray. Ray, what is your practice? Actually, we are asking this question because it's not only the high-income countries, there are more than 50 countries this telecast is going on. What is your recommendation, or what is your practice? You start with CPAP, and which kind of a CPAP, and after, or if the baby is intubated, then which mode you are using? I'm talking about less than 28 weeks.
Yeah. So in our practice, we'll support babies even down to 22 or 23 weeks with nasal CPAP. But once you get below 25 weeks or so, kind of thinking about how you're administering surfactant. So in our center in Rochester, Minnesota, similar to a lot of centers in the United States, the main way we give surfactant is with intubation and through the endotracheal tube. We are part of the Aerofact Tube B site where they're using nebulized surfactant, so that's an option for some of our newborns that qualify for that study. But for most of our infants, if they're less than 25 weeks, we end up progressing to intubation, but we do it kind of based on the response to the resuscitation.
And after extubation, if let's say baby get intubation for 24 hours, and then which mode you use for after extubation?
Yeah, so for our infants, we do evaluate them for using that intubate, surfactant, extubation, or ensure technique. And then typically when we extubate, we'll first try nasal CPAP, although if the infant is kind of borderline for extubation, we might do NIPPV, or we'll use NIPPV as kind of a treatment rescue if they're not tolerating nasal CPAP.
Sorry, Dr. Ola, I just want to know about this Helix trial a little bit more, because originally I'm from Pakistan and they are doing pulling the babies. What do you, after this trial, we should do it or we should stop? And they are getting good results from some of the centers. Of course, the availability is only in the big cities, in the metropolitan cities. But what do you think about this Helix trial? In total.
Well, when you see how heated this debate is, I think we have to be careful drawing too firm conclusions.
Exactly.
I'd like to say that by reading the Helix article, I think it's a good study. I mean, it's hard to criticize. Some people say that they are looking at different patients than in high-income countries, and they don't monitor EEG, which is true. So they cannot trust their results. But anyway, this was their setting, and it's reflecting. The results are reflecting the settings of these participating units. So what they should do in Pakistan or other countries, it's very hard for me to give any recommendations. I just say that we have to follow the development in this field and maybe do more studies. But I remember the first study from a low-income country. I think it was by Nicky Robertson in Uganda, published in 2011 in the Lancet. And he showed also that hypothermia therapy increased mortality, I think, 6-fold. And so I think that was a warning that we have to be careful. And the reason for this difference between high and low and middle income countries, we can only speculate about that.
We have a question about strategy to achieve ventilation without cord clamping and extremely low birth rate. How can we ventilate babies without cord clamping if they need to be ventilated and doing delayed cord clamping at the same time?
Well, I guess the question is about whether we could resuscitate or ventilate with an intact cord.
Right.
Yeah. So, of course, that is feasible. And there is one study from US by Katerian and co-workers in San Diego showing that it's feasible. There was no advantage in this study compared to delayed cord clamping. But we know that there are now commercial trolleys where you can do the resuscitation with an intact cord at the bedside. And of course, from a theoretical point of view, there are many advantages to doing that. I think still we have to wait for more data before we really would recommend that.
Okay. Dr. Raymond, there's a question about like when you switch from CPAP to nasal cannula, either high flow or low flow, how you convert the pressure to flow? How do you know that this is the flow that I'm going to use to step down, not step up in nasal ventilation?
Yeah, and I think that's a great question, and that kind of goes to some of, I think, the art of medicine. There's that various equations like the Wilkinson equation I shared where you can kind of estimate what the pharyngeal pressures might be based on studies in other infants to see if that's kind of a step down in flow if you're going from nasal CPAP to high flow nasal cannula. So that's something people can start with. And I think a lot of us in clinical practice, we kind of get a feel for, what sorts of high flow are weaned from CPAP for babies of certain sizes.
Do you use that formula, or is it something that just to guide you, it's not really very accurate?
So I've occasionally referenced that formula, but to be honest, a lot of times in clinical practice, I'll just kind of empirically use a certain amount of high flow, like maybe 2 to 4 liters for a baby of a certain size. Going from nasal CPAP of 5 centimeters of water is kind of a wean if we are going from nasal CPAP to high flow. But I think that points that, that's another area where the evidence and kind of the best way to wean babies off non-invasive support is lacking, and there's a lot of different style approaches that are probably all reasonable with the evidence we have.
I have actually a comment from Dr. Boris Kramer. It's a comment I'm assuming that's about hypothermia treatment. The comment is we should point out that every center should collect their own data, compare it with the national and international data. Just a comment with one.
Yeah, I think that's a good comment. But still, we need larger materials and randomized studies.
Okay, great. Now you have any questions?
I have one.
Go ahead.
Ray, the different modalities, because Dr. Poland is going to be meeting in tomorrow. And if you ask him, the bubble CPAP and the bubble CPAP and the bubble CPAP. I use personally bubble CPAP in my previous job for a long period of time with a very good. What do you think? What kind of CPAP you are using?
Yeah, so we use CPAP that's ventilator derived. So in our hospital, we use the Hamilton G5 ventilator, which provides our CPAP circuit. But last year, when we were kind of looking at potential ventilator shortages with COVID-19 and kind of a fear that our ventilators might have to go to different parts of the hospital, we looked into bubble CPAP. And some of my partners who have practiced in other settings have used bubble CPAP and high acuity level 4 NICUs and similar regions to where I'm practicing. So I don't think that one way versus the other is that there's a lot of evidence that it's superior or inferior.
And last question to Dr. Ola from my side. Again, the same thing with the end of life decision to stop the resuscitation 20 minutes, because it's happening after 20 minutes of good CPR, and at least in 20 minutes you gave like 4 doses of epinephrine. There's some heart rate, like 30, 40. But if you continue on that thing, I had one study that shows that there is chances of 90% brain damage. So, what do you think that this 30-40 rates is because of your CPR and because of your epinephrine? You should stop at 20 minutes and just tell the parents that you did everything, and after a few minutes the baby passed away, or you continue like 30 minutes. I mean, it's a real dilemma. I know it's a very difficult for all four of us to say something, but people are, and Ray, you also can comment on that, that people are thinking, really want this thing because nurses and the CPR committee said, no, we need a ACE history from the monitor, then you should stop. So, Iman, you should also comment, all three of you. One by one. From Ola, then
Dr.
Ray.
Ola.
That is a big question, and I think we should have a seminar on that. I can tell you that I was not happy with the previous guidelines saying stop after 10 minutes because, as you know, during a resuscitation, 10 minutes goes so fast. I mean, very fast. So when I was very young, I continued till 30 minutes, but the recent years I usually stop around 20 minutes if there's no response. Then we also have time to inform the parents and we have some time to make some considerations. So I feel more comfortable with the 20 minutes limit. But if you ask me about data, I cannot give you much data.
The problem is that when you have some heart rate, like you have a heart rate below 100, but it's not really a very, it's not like 0, but it's like, let's say 60 to 80. So what do you do? Now, if you have a good saturation, the first thing you need to make sure that you're ventilating the babies. And you're giving good pressure, you have a chest movement very well, and you have no other things that you can fix, for example, pneumothorax or anything that you causing problem with your resuscitation. But stopping at 20 minutes, and if you only have a heart rate of, let's say, 60 to 80, will be a very difficult decision, and it's sometimes you need to kind of continue a little bit more and then see how it happens, or move the baby after 20 minutes, just to kind of make sure that you're doing everything that you should do. Maybe do an X-ray or something.
So I never stopped after 20 minutes if there's a heart rate of 60.
Yeah, 60 and above, we don't have that problem.
But how long are you going to go for?
And that's the question. But I'm talking about that after 20 minutes of resuscitation, you have a heart rate of 20, 30, 40. So Ray, now it's your turn to comment on that.
Yeah, so I think that's a really hard question, and it also depends a little bit on what's kind of driving the infant need for the resuscitation. If there's a congenital airway anomaly or something like that, where potentially changing your modality of ventilation to high frequency or something, I might consider that. But I agree with what Dr. Logstad said of kind of that discussion point is so important. And it's something in my clinical practice, sometimes I'll even bring the parents into the delivery room or resuscitation room and have those conversations with them about, if that is my recommendation that we stop resuscitation based on the physiology we're seeing in the baby.
Would you go with their wishes and say, no, we have to continue?
Well, I think that's a hard thing too. And I think that's where you have to kind of sometimes, let them know what we're thinking and kind of what we're seeing in the patient. And if the baby's, not responding to resuscitation and keeps progressing, if we're continuing it, it's probably not going to change the outcome.
Yeah, I think the main point is that you make sure that you did everything that you should do to make the successful resuscitation. Hypovolemia is not really there. You give fluid pulses, and so it's difficult.
That's true, but also if you go beyond 20 minutes, you may have a blood gas, and you can look at metabolic acidosis.
Yeah. Right now, the bicarb is out of the resuscitation. Now, the only thing that NLS, they say that you can give bicarb if you're really 100% sure that this is a cardiac origin need for resuscitation. You can give bicarb, but the NRP, no, you can need that.
But if the base deficit is not too high, maybe the prognosis is better. So
Thank you very much. This is really very, hot topic, exciting, and we
Yeah.
can just discuss this until tomorrow. But I think we have, covered the important points. I'm sure you're going to get a lot of more questions coming our way. Thank you very much for taking the time. We really enjoyed this session. This is really a very good start for the day. Please continue to be with us if you're not too late. Actually, for Dr. Raymond, it's the beginning of the day, so you can stay with us.
Yep, just 6 a.m. here in Minnesota.
No, yeah, we're at the end of our day, so that'll be good. Dr. Ola, thank you very much. It's always a pleasure. Next time we're gonna see you in person.
I hope so. I hope so.
And also,
Thank you very much.
thanks a lot, Ray and Dr. Ola. Thanks a lot.